Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our weekly webinar series entitled Medical and Public Health Considerations of COVID-19. Today, we will be having two outstanding presentations. The first presentation will be on the epidemiological modeling of the impact of COVID-19 on hospital systems, and the second one will be on an update from the front lines from the Rio Grande Valley. Next slide, please. I'd like to thank our webinar partners for helping to promote the program to their members. Much appreciated. Next slide. This webinar will be recorded and be posted on our website by Friday. You'll be receiving an email after it gets posted. This webinar, as well as all the other webinars in our series, are on our webpage at acmt.net/COVID-19 web. We also have prepared a series of Q&As to accompany many of the webinars, which can be found on the website as well. And then if you have any questions specifically about the webinar series, feel free to contact us at info@acmt.net. Next slide. There will be a Q&A at the end of the webinar today. Usually we carry the Q&A for about 15 to 20 minutes or so. So for those of you with questions, we welcome your comments and questions. Please put them into the Q&A box or the chat box on the WebEx or on the chat box on YouTube or Facebook Live. Next slide. I'd like to thank my co-moderator today, Dr. Andrew Stahlbach. Dr. Stahlbach's a member of the board of the American College of Medical Toxicology and is a professor of emergency medicine at Johns Hopkins University. Next slide. I'd also like to welcome our guest moderator today, Dr. Lisa Moreno. Dr. Moreno is the president of the American Academy of Emergency Medicine and a professor of emergency medicine and the director of research and diversity at the Louisiana State University Health Sciences Center in New Orleans, Louisiana. Next slide. At this point, I'd like to turn it over to Dr. Stahlbach, who will introduce our first speaker.
Thanks, Paul. It's my pleasure to introduce Dr. Eili Klein. He's a colleague of mine at Hopkins. He's an associate professor in the Department of Emergency Medicine with me at the Hopkins School of Medicine. Dr. Klein is a mathematical ecologist and epidemiologist whose research focuses on the role of behavior in the spread of infectious diseases. Today, he will explain basic epidemiological modeling concepts and how they relate to policy responses.
All right, thank you, Dr. Stahlbach. It's really nice to be here and talk about a lot of this stuff. It's somewhat exciting to talk about all of this stuff because it's been a while since I've really sort of gone back and talked about the epidemiology and the background around a lot of these slides. So Dr. Stahlbach said I'm an associate professor in the Department of Emergency Medicine. And a lot of this work is being used to help plan surge capacity and plan actual transitions within the hospital for dealing with COVID-19, and as well as several other hospitals across the state. And these the slides, well, a portion of these related to actually modeling COVID-19 are actually going to the state as well. Just as a quick disclaimer, I don't have any disclosures, but this work was funded by the CDC, and a computational assistance has been provided by the U.S. Army and the National Center for Supercomputing Applications. So I'm actually going to go really far back, in part because my PhD was on malaria, and in part because I haven't talked about it in a while and it's fun. But in part because modeling and the modeling of diseases actually goes back to 1911 and was related to the development of malaria and understanding malaria transmission. And I'm not going to actually go through a lot of that, but the key point here is that people, this guy, Sir Ronald Ross, understood that individuals who were susceptible to malaria could then become infected. So you see this S and then this I. People became infected at this rate H, which had to do with the number of bites they got today, whether number of bites they got per day, how many bites from infectious mosquitoes, how many of those mosquitoes then survived, and so on and so forth. So again, obviously parasites and viruses are different, but from a very simple modeling perspective, there's some similarities in the sense that people went from being susceptible to being infected, and then at some rate they would lose their infectiousness and go back to being susceptible, right? And so there's a bunch of math that can be written down about that. And he was the first person to really write that down. And then in his 20s, another group of people, Kermack and McKendrick, actually developed the first what we call SIR model. And the S stands for susceptible, the I for infected, and the R for removed. And people would basically, in a very simple way, people become who are susceptible become infected at some rate. And those infected individuals either recover or die and move into this removed category. And the reason it's sort of called removed is that they're no longer contributing to infections. And that becomes quite important. Now, the very important aspect of this is the really sort of basic assumption is that these equations, and there are a bunch of mathematical equations associated with it, assume that people were sort of like atoms in a chemical equation. And this actually is developed from sort of the way chemical equations were modeled, and in that anybody could randomly bump into anybody, right? So sort of the way in a drinking glass you would see if you drop this fluid in, it will slowly dissipate throughout because you get random movement of individuals as the red turns into pink. So you can write down these equations, and the key insight was that this beta term, which is the rate at which transmission occurs, is really two terms, which involves how often susceptible individuals bump into infected individuals and how often that leads to infection, right? So you can have lots of bumping in, but if the probability of transmission is low, you won't have people transitioning to infected very quickly. And then once they're infected, at some rate, they can go to becoming recovered, right? And now you can make these much more complicated. You can add additional components to the disease so that you have an exposed category. Individuals who become exposed are infected, but they're not actually transmissible for a period of time. You can add in other types of susceptible individuals. So you can have people who are more susceptible, people who are less susceptible. You can have different types of infections. All of that can be made much more complicated, but this is a very basic way that you can model a disease. Right? And the reason we do that is that it provides this nice mathematical graph, right, here that shows how a disease progresses, right? And you can see that over time, those infected and susceptible individuals interacting with each other and then the infected individuals clearing give this nice little infection curve here that goes up and then comes down, whereas the total number of susceptible individuals falls and the total number of recovered individuals increases. So you can see that in this model, 80% or 85% of the people in the end become infected and then recover, but in no time do you see more than 20% of the people infected. So those are sort of some of the insights that you can gain from a very, very simple model. Now, there's lots of different diseases, and they all have different aspects of biological aspect and epidemiological aspect. And the first models, SIR models, were basically formulated around measles, which is a nearly perfect example of an SIR model disease. So you can see here, the red line is the SIR version of the model, and the blue line is the actual data. And you can see, while it doesn't fit it 100% accurately, it does fit it very, very well. Oops, I'm going the wrong way. So you can then take all that data and you can look at that model, and as I showed you, the model went up and then came down, but you didn't see this pattern, which is what you see as a pattern of measles, right? So you can see the disease goes away and then comes back, goes away, comes back, goes away, and it's actually quite regular. And so that gets you to sort of start thinking about why does it look like this relative to what our prediction was, right? And the reason here is that actually it generally actually does go away. So you have sort of that full curve in a community, but then gets reintroduced. And the reason you get this nice curve, right, these nice regular curves that go up and down, actually has to do with school terms. So this is sort of the start of school. You get a huge increase as all these kids come back together, and then goes away, and then comes back. You get a little bump here in the winter as you have some people coming back together. And so, even these simple models can be used to understand sort of how social dynamics and behavior impact sort of the basic dynamics of a model. And you'll notice actually as well here, and this is one thing that I really like to point out, is that it's not as regular in this period right after 1945, which is coincident with what we call the baby boom, right? And then so you can see that actually the number of kids and the number of babies was much, much higher during those years, and that led to less regularity in the rate at which this disease was going up and down. So you can see how the epidemiology and the biology can sort of be relatively easily defined even within a very simple model. Now, the problem is that all models are wrong, but as a famous statistician said, some of them are useful. So George Bach said that. Right, so if we go back to this very simple model with susceptible, infected, and removed individuals, you can see that, and I'm not going to go through all the math, I'm happy to if somebody really wants you to later, but if you rearrange these terms and you look for, these are called ordinary differential equations, you look for the point where this is equals 0 and what pushes it off to start growing, you find that you get this equation out, which is basically the transmission rate times the number of susceptible individuals who are completely susceptible at the beginning over the recovery rate, which is what we call R0, right? This is the basic reproductive number. And when this number is greater than 1, that means the disease is going to spread. And when it's less than 1, it means the disease is going to die out, right? And I'm sure all of you have heard at least some level of talk about the basic reproductive number when talking about COVID, right? And so that is why it's such an important number, because if that number is over 1, the disease is going to start growing. Now, the issue with the basic reproductive number is that it is a theoretical concept. It is the number of susceptible individuals who are completely susceptible at the beginning of an outbreak when you introduce one infected individual. That, of course, is not a real place, but at the beginning of an outbreak, when you have a large number of susceptible, it's approximately equal to what we call the effective reproductive number, which is the number of people which is the same basic equation. Again, if the effective reproductive number is greater than 1, it's growing. So this is basically R0 times S, right? The proportion of the population that's still infected or still susceptible, right? And so what you can see here is that at the point where we hit the peak of that curve, is when the R, the effective reproductive number, actually starts to go below 1 and starts to die out, right? This is also what we call herd immunity. When you get to that point, when enough people when the susceptible population falls below this point, you now have herd immunity. But you'll notice, and this is one of the things that people don't talk about a lot when we talk about how do we get to herd immunity, even once you get to herd immunity, there's still a large number of people who are going to get infected and remain infected for quite a while. So getting to herd immunity is one thing, but once you're there, you still have to then have the infections die out. So you want to get to this point without having a large number of people get infected, and that's the number of people you really need to vaccinate. So again, all of these things come around from a very, very simple set of equations to get to what are some pretty important epidemiological concepts. So as you can see, that R0 is really important because it drives important things like how many people need to be vaccinated to stop transmission. So the higher that R0 is, so influenza, the argument is you only need to vaccinate about 50% of people to get to be immune. Whereas measles is 95% of people because the R0 is estimated to be 15. And again, one of the big issues, though, is that R0, as I remember I was telling you, is made up of two things. In that beta term, it's made up of the probability of transmission times the number of contacts and over the time span of recovery. And if you change one or the other of them, you can get the same number, right? Because it's just a ratio. But changing them can lead to, even though you have the same R0, can lead to differing epidemics. Right, and so you can see here, this red curve and this blue curve have the same R0, but they end up having very different epidemiological trajectories, right? Where one is slightly higher and faster, and the other one is slightly later and a little bit broader. Right, so again, the R0 itself and how fast transmission and or recovery or the length of recovery is affecting how infectious and infected somebody is, and impacts how quickly a virus or a bacteria or any sort of infectious disease will spread through that population. So when we talk, so now I'm going to move a little now. So that's sort of like a lot of the background on terms of how mathematical modeling is sort of some of the major concepts behind it, and how that then gets transmitted into how we think about COVID, right? And one of the big issues in COVID is that I just told you all of this information about how the basic R0 number can give you all of this information. Well, it can, and it's very useful, but a lot of that works when things are sort of regular. So when the average transmission, when the average number of people who are infected by any single individual is 2, then it's straightforward and you get a very nice, simple mathematical formula. That works fine as long as the average and most people infect about 2 people, right? Unfortunately, in COVID, that's actually not what happens, and we actually have this what we call overdispersion, meaning a very small percentage of the individuals are infecting a large number of people. Right? And so you can imagine that you can have an R0 of 2 where 100 people, everyone infects 2 people. Or you could have one person who infects 200 people and everyone else infects 0. Right? That's the same R0 if you're looking at the number of people infected by on average, but it's a very different effect in terms of the dynamics of the disease as well as how you would think about controlling that. Right? And so in order to model that, we actually move towards more of a individual-based model, right? And so the difference between an individual-based model and sort of these very simple compartmental models is that the math becomes a lot more difficult, and the computation becomes a lot more difficult, right? So we're running this on a set of supercomputers, and we basically have every individual in the state of Maryland, and plus several surrounding zip codes. So you can see this is the state of Maryland. We have something like 9 million people, and includes every individual in Maryland, as well as DC, Northern Virginia, parts of Delaware, which is over here, parts of Pennsylvania at the top, and parts of Virginia and West Virginia, all of whom send individuals to the hospitals in Maryland. And the way we set up the model is that every individual is situated within a household in Maryland, or the average number of people, zip code, and they they infect individuals. They're much more likely to infect an individual in their household than to infect somebody outside of their household. We also include things like nursing homes, where individuals it's like a household. And also prisons and other things like that. And so then we use that information, and then we also assume that you're more likely to infect somebody outside your house in your local zip code, or a nearby zip code, or a big zip code nearby. So if you live in Frederick County, you're more likely to infect someone or be infected by someone in Baltimore City or in DC than somebody in Garrett County or on the Eastern Shore. So that's all of that set up under the hood, and then we assume that the disease was introduced into the population, probably most likely in this region outside of DC, sometime in early February. We then have within the population, and the reason that we built it with as an individual-based model in part is because we wanted to have this differences in contact rates. So we know that individuals have this age-assortative contact patterns, where younger individuals are more likely to have contact with younger individuals, and older individuals with older individuals. So you can see right along this thing, there's on this figure on the right, there is a sort of almost a uniformly straight line that goes up, showing how individuals most of their contacts were people approximately their same age. Although there are these wings here which account for people who are younger, living in houses. So young kids living in houses with older individuals, obviously kids living with their parents, and then some with grandparents. So if we assume those sorts of types of age assortative contact patterns, and we also assume that individuals have very heterogeneity in their contact patterns, right? So most individuals have a set number of contacts per day, but some individuals have really high numbers of contacts per day. So you can imagine a waiter or a salesman or somebody, a religious figure who, runs a religious service and has a handshake with every person who comes through the line at the end of services, or a waiter or a bartender who's interacting with a large number of people per day, right? And so those things play into how likely you are to have a super spreader event. And finally, and the main reason we built this was to also have the ability to sort of look at where people were likely to go to the hospital when they became sick. So individuals that become sick are assumed to go to a hospital based on where in the past the people from that zip code have typically gone to an emergency department in Maryland for respiratory illness. So you can see there's a lot of aggregation, and that individuals typically in this area in the sort of central region tend to go to one of these yellow hospitals. People down in this lower region tend to go to one of these red hospitals, and if you're out on the shore or out in the far western part of the state, you're likely to go to one of those hospitals mainly rather than any of the other hospitals, right? And so that sort of drives a lot of what we're likely to see in terms of where people are going to go when COVID surges, whether it's in this prior spring as we were building this, or predictions for the fall as to where people are likely to go. So you can see this is some of the early data we had, where this is showing how we were fitting the data to the model. On the right here is sort of the model results based on the dashed lines are the model results. And the dark blue line is what we were fitting to, which is the state occupancy level. So we basically fit the model just to the state occupancy level in terms of number of people in the hospital for COVID. And then you can see on the right, it automatically falls out from the model where people end up. And it does a decent job of predicting the relative use of the hospitals by individuals. And actually, some of the ones that are the worst is actually not because the model is poorly performing, but because of decisions around what happened. So in this case, Johns Hopkins, a lot of the patients at Howard County, where we predicted a large number of people, were transferred to Johns Hopkins, and that's why partly Hopkins was higher than our predictions. And so that's sort of one of the issues of system hospitals and how those systems are connected, and why we're using this model to sort of help systems in the state sort of derive better optimization patterns for where people should go given potential surges. So the next part, obviously, is we've taken all of that data and we fit it as well as we can to what has actually happened, and we want to see what's going to happen going forward, and can we potentially control a surge 2.0, and what are the factors that are likely to be most important in leading to surges. So you can see here, this is our estimate of how things are fit. So we basically assume that there were contact patterns that were at a certain level prior to COVID happening, and that at some point there was a dramatic reduction over a short period of time in people's behavior. And this is well documented. We all know this. They closed the schools, and then there was a closing essential businesses, and they shut down the entire state, right? So we had a shelter-in-place order. And at that point, then you have this really long period of time in which the transmission rate seems to be really, really lower. And then it starts to increase slowly. And we're still working on some of the aspects of this, whether or not some of it is related to summer transmission, whether some of it is related to mobility, whether some of it is related to mask wearing. But in general, we've seen much lower transmission through most of the summer. And then we're wondering what's going to happen as transmission increases. And there are a couple of reasons why transmission could increase. Now, again, remember I told you that there's that beta term, which is made up of two things, which is the transmission probability and the contact rate. And it's always very difficult to separate those two things. But in essence, what we are looking at is two distinct issues, right? One is how often does contacts occur? And the second is, given those contacts, how likely it is that someone who's infected ends up transmitting to someone who is susceptible. right? And so we know that certain things control those two factors, right? So you can make alterations to behavior so that you reduce the contact. And the second is you can change your behavior so that the probability of a transmission is actually reduced. On the other hand, there's a third factor, which is sort of environmental. And so as you all know, in the winter is when we have respiratory infections, and in the summer, we generally don't have respiratory infections. And while there isn't a lot of great evidence one way or the other as to what are the exact biological mechanisms behind that, there's a lot of evidence that seems to suggest it's related to humidity and potentially to some biological mechanisms in terms of individuals' mucosal barriers being more effective in the summer versus the winter. And if that were the case, then we would expect that even if you had the same level of contact patterns in the winter as you do in the summer, that you would have more transmission in the winter. So these increases here that we assume starting, and I'm running new models now that run this obviously later, starting in late September or late July or early August, assume that we can have either a rather fast increase in social distancing, which could be due to opening bars and restaurants, things like that, or you could have a sort of much longer, slower phased reduction in social distancing, which was sort of a little bit of what we've seen as people slowly get bored or get tired of being home all the time and start to move around a lot more. And those things can sort of happen over a sort of a very short time frame or a very fast time frame. So we look at three different time frames, one which is rather fast between now and September, one which was more moderate between now and the end of October, and one that was much slower, which was now between now and the end of the year. Right, and again, in all of those, you have this sort of slow increase in social distancing or reduction in social distancing, or potentially increase in transmission due to changes in the weather. In addition, one of the potential interventions that's been suggested beyond just sort of lockdowns and other types of interventions to reduce transmission is to what I call a three-barrel analysis, which assumes that older individuals are likely to maintain reduced contact rates that are relatively lower than other groups. Now, you could argue that there's potentially some policies in place that you could do to augment this, but we know in general that people who are most at risk are likely to be the ones who are most likely to protect themselves. And we also know that as cases rise in places, people in general will start to protect themselves, whether or not the government introduces policies to change that, right? And so, in fact, I should have put this in here because it's one of the things I study, but if you look at sort of the mobile phone data, you can see that people's mobility starts to drop in the weeks and days before shelter in place and other official policies were introduced. And so people actually were already changing their behavior prior to implementation of many of these things. So the other major policy that we looked at here was how can you dramatically reduce the number of contacts, right? So again, as I said, we assume that there's this heterogeneity in contact rates, and there's a small number of people who have a large number of contacts. And again, as I said, there's an over-dispersion to transmission that has been recognized in SARS, which is largely due to having somebody with a large number of contacts be infectious at that exact moment when they are infectious, right? So, and have a large number of contacts when they are infectious, right? So there's somebody that keeps a log of these on a website somewhere, but you have the famous examples of in South Korea, an office building where it looks probably one or two people were infectious and infected half the people on the floor, or the choir event in Washington where one person was sick and infected like half the choir or more. So you have these sort of super spreading events where a large number of contacts interacts with somebody who's infectious. And so if you can dramatically reduce the number of contacts that anybody has, that really prevents people from having these higher number of contacts, that would be another potential one, right? So that's basically what we did at the beginning. We had these huge lockdowns that shut off contacts, right? We shut down any gatherings over 10. We shut down bars and restaurants and all of that stuff. Well, I'm going to quickly go through the results because I know I'm running out of time. So as expected, right, the larger and faster the decrease in social distancing, the greater the probability and size of the surge, right? So if you assume that there's a 30% reduction in social distancing or a 30% increase in transmission, that's going to lead to a much bigger surge. Whether if it's slower, then it'll be a lower surge. If it is faster, then it'll surge faster. And if the reduction in social distancing is larger, then the probability of a surge and the height of that surge will be even larger. And you'll notice that this is looking at estimating daily hospital occupancy, and that this line here is where we were at the peak back in March, where everything felt stressed in Maryland, and that was under 2,000 beds were occupied by COVID patients. And this is expecting, even in sort of this moderate, slow process of a surge, that we'd be up to 5,000 beds, and in this case here more than 20,000 beds needed. And currently, right now, again, they've made some changes, but prior to COVID, we had about 15,000 beds available in the state completely, not for COVID, just in total. So these would be quite intense, significant surges. So looking at the first policy, can just older people reducing their social distancing make a big difference? And you can see that it makes some effect. It does have some effect, but it's not huge, right? So the more that they do that, obviously, the more effective it is. But again, it's reducing off the top, but not such a huge amount that it will dramatically change the outcome. And that, of course, is because, while older individuals are the most likely to be hospitalized, they only account for a small proportion of the population. On the other hand, if we can restrict the number of super spreader events by restricting the number of daily contacts to be much lower, you can see in that event, if we keep that below 10, there's a massive reduction in the probability and the size of a potential surge. So this is why I and several other people are advocating things like keeping bars and restaurants closed and reducing indoor dining and not having indoor dining, because whenever indoor dining has been opened up, that's when you've seen dramatic increases in transmission. And this is just sort of looking at a slightly more recent one, looking at the same thing but over a much shorter time frame, fit a little bit better. Finally, again, as I've mentioned before, there is a possibility that everything we've seen throughout the summer has been affected by this summer effect, that summer weather is lowering the severity of infection and potentially lowering transmission, which would mean that many of these places that have been hit hard will be hit significantly harder going into the fall, and thus, efforts to keep the level of infection lower now will make it longer and slower for those things to build up in the winter. If you start with a large base of a number of people infected, when you go into the fall, then that could lead to much higher surges. And the other major thing that obviously I've spent a lot of time modeling is flu. And one of the things that people are very worried about is, will flu and COVID overlap? And this is just some evidence from Australia that their ILI hotline, after they got rid of, when they're looking just for COVID, did see an increase starting in May, so that's their winter. But you can see that actually, and you might not be able to see because it's kind of small, but you can see that they've had very little flu so far. And very few flu isolates. And that would make a lot of sense, since flu is a respiratory pathogen, so same as SARS. And we're doing a lot of different activities to maintain social distancing and reduce transmission. And thus, you would expect that flu, as I've sort of explained with these very simple models, would spread slower, right? Because its R naught would be, in essence, lower. Its effective reproductive number will end up being lower because the transmission will be lower, right? So that beta is going to be lower because everybody is social distancing. And particularly flu is particularly important. Children is an important place in which flu spreads. And again, if schools are closed, then you would expect flu to be very unlikely to spread in those communities. And so everything will proceed on a slower timeline, and the time when we would expect flu to peak, which is usually late December, early January, should actually be much, much later and much, much lower. However, of course, the problem is that the symptoms of flu and COVID overlap, which makes identification more difficult. And finally, these are just some slides showing that when we do these predictions are done at the hospital level across the state. So every hospital gets these predictions as to forecast as to what is likely to happen given changes in behavior over the next several weeks to months. And that's all the slides I have, and basically on time.
Thank you, Dr. Klein. This is Dr. Moreno, and I am now going to introduce our next speaker, and then we'll take questions at the end during our Q&A portion. I have the privilege of introducing my colleague, Dr. Minerva Romero Arenas, who is an assistant professor at the University of Texas, Rio Grande Valley, Department of Surgery. Dr. Romero Arenas is an endocrine and general surgeon. Today, she will be providing us with an overview of the Rio Grande Valley with a background on the socioeconomic disparities that have been highlighted by the impact of the COVID-19 pandemic. Dr. Romero, I will turn it over to you.
Thank you so much, Dr. Moreno. It's a pleasure to be here, and thank you for the invitation to participate. I'm going to go ahead and give you a little bit of an orientation to where we're just talking about when we discuss the Rio Grande Valley. And we're really talking about 4 counties that are located in the southernmost part of Texas. We have Star, Hidalgo, willI, and Cameron County. Most people know us from the vacation destination, South Padre Island, which has been in the news due to the pandemic as well. But it's a very popular destination for spring break. We have 4 counties that are medically underserved and have some of the most prominent disparities across the board in the state and really in the United States. The COVID-19 pandemic, like many places in the US, didn't really hit us for the first few months. You can see from this graph here, the number of cases has risen exponentially really since about June. I've labeled a few stars that will hopefully help orient you. And right around April is the time where we hadn't really seen too many cases. We were still in the lower hundreds, really. And around May, we started to initiate, as you may recall, Texas was one of the first states to reopen. At this time, face masks were not required. And after the first few weeks, we continued to reopen and really had an exponential climb over that next month, to the point where in early July, face masks were finally made a requirement by the state governor. Shortly thereafter, you can see that it was really, it seems like an impossible task to really get this virus under control. And unfortunately, our region was struck with a Hurricane Hannah, that struck the Rio Grande Valley at the beginning of this month. As of today, we are up to 40,000 cases, and all but 2,000 cases developed since June. So just in those 2 months, we have over 1,300 deaths, and generally, the census across our hospitals is about 1,100 to 1,200 patients. To put that into perspective, the Rio Grande Valley accounts for less than 5% of the state population, yet we really are seeing a significant number of the cases. We, at 40,000, are seeing almost a fifth of all the cases in Texas, we're seeing about 15% of the deaths. We're obviously seeing a significant number, an eighth of the patients that are hospitalized. And why is this particularly devastating to the Valley? We're a small community of about 1.2 million people. We have a number of disparities, which include having a high rate of obesity and uninsured patients, as well as all of the other comorbidities that go hand in hand with that. We have a significant portion of families that are considered mixed status, patients who really, are not counted as part of the census within the community because they're undocumented. And that affects the funding and the resources, obviously, that come to our health system. The population, the community doesn't have access to some of the basic services. You can see that household with broadband internet access is as low as 50 to 65%. We actually do still have something called colonias, which are neighborhoods in which there's no water or electricity in some of the areas here. The median household income is low. We have about 30% of the community that lives in poverty. In comparison to the Texas state population, in Texas, there's about 15% of Texans that live in poverty. We also have a significant number of patients who have limited English proficiency, with the most common language being Spanish. And we're seeing 65% of the community with high school education. Many patients, many community members live in multiple generations within the same household, and that has been particularly challenging during the pandemic because it makes isolation as required by the quarantine. It makes it nearly impossible when you have children, parents, grandparents, and extended relatives such as in-laws and adult siblings and their family units also living within the same household. So putting this back into the perspective of what are some of the aspects, what we call the social determinants of health. Stark County, for example, really only has one hospital. In Willacy County, there are 0 hospitals. And so really, in Willacy County, there is only the availability of emergency medical services to transport patients to one of the neighboring hospitals, whether that would be in Cameron or Hidalgo County. A drive like that could take a patient about 30 to 40 minutes or more. In Cameron and Hidalgo County, there really are no public hospitals. The nearest level 1 trauma center to this region is going to be located either in San Antonio or in Houston, Texas, which are over 300 miles away each. And as I mentioned, all of our counties are considered medically underserved, which poses a challenge in terms of the funding, the personnel at all levels, including the respiratory therapists, the nurses, the physicians, the physician's assistants. All levels are really impacted by this. And we don't have a tremendous amount of specialists and subspecialists. One of the technologies, for example, that had emerged as a potential treatment for patients with COVID is ECMO, or extracorporeal membrane oxygenation, and that is simply not available here. So a patient who may be considered a candidate for that would have to be airlifted to another specialized center, up 300-400 miles away. So those are the unique circumstances that are sort of made the perfect storm for the COVID-19 pandemic to really devastate this community. It's been noted that we're a large town, and there really isn't anyone here who hasn't now been personally affected. And, and a lot of people who really speak to the fact that nobody in the Valley now doesn't know, everybody knows somebody who has died from COVID. So with that, I'd like to close my remarks. Thank you again for the opportunity.
Thank you so much, Dr. Romero Arenas. We have some questions from the audience. Dr. Arenas, they are asking whether patients are worried about presenting for testing or treatment because of immigration issues. Do you find that in your community?
Yes, that has been a really pressing concern. As some of you may know, earlier this year, the administration had actually instated what is called a public charge rule, which basically meant that if you access specific public services that were considered for that immigrant to be a tax on the community, that those kinds of actions would be considered against a person's application for permanent residency and immigration into the country. And so already we were seeing a significant campaign, obviously, to make the public aware about that. Thankfully, that specific rule has been rescinded or temporarily placed on hold, at least by the administration. However, the community really does fear that it will continue to be something that later gets used against them. Also, that has actually impacted our contact tracing efforts because people don't want to divulge specific names and sensitive personal information of family members whom it may also be at risk, or perhaps someone who actually gave them the infection, the COVID-19 infection. But unfortunately, that's a really essential part of this. And so we're working on public education, public health education messaging to help the community be aware that the contact tracing is going to be essential.
Thank you, Doctor. We have a question for Dr. Klein. Any of your modeling strategies been used to predict ventilator use and ventilator shortage in COVID 2.0? I think you might be on mute, Dr. Klein.
That's weird. Hi, hear me now? Sorry, I didn't know I'd muted myself. To what you were talking about, we don't specifically model ventilators. We model the use of the ICU versus non-ICU, in part because as we were moving forward through in the spring, one of the things that was emerging was changes in the use of ventilators and how they were being used. So we're looking more at what's the severity of patients and the likelihood that they may need ICU care.
Okay, so we have a question. I'm sorry?
I'm seeing the polling one. Is that
Yeah,
what
we have a question for both panelists from Melissa Klepper saying, what is the source of funding for hospital care for those with no insurance or who are undocumented? And are hospitals getting Medicaid funds or directly billing the patients? So maybe Dr. Arenas could go first in addressing that. And just make sure you unmute yourself, Doctor.
Yes, so unfortunately, the sources of funding are a little bit complicated. For the patients who are undocumented, Texas is not a state that will allow most avenues of funding for those patients will not come from either federal funding or some specific restricted funds from the state. So that is certainly a significant significant challenge, and a lot of the hospitals down here rely on charity care and have very generous and complex programs to help patients observe some discounted, basically at cost care, so that they can access the health system despite their undocumented status.
So I'm gonna answer it in a slightly different way. Obviously Maryland and Texas have different policies around Medicare expansion and all of that stuff. But I think one of the big issues, and Dr. Arenas spoke to this a little bit, is that undocumented individuals and individuals who, particularly in the Hispanic community, have been more reticent to access care, whether it's because of funding or because of their status, and that has led to them showing up potentially in later stages of the disease when it makes it potentially more severe. And we're seeing that in Maryland somewhat, and that has led to outreach efforts to try to reach into those communities at a sort of an earlier time frame, and to allow for testing in those communities, to provide testing in those communities, and to get them access to care at sort of an earlier stage when outcomes may be better.
Okay, we have another question that is something that I know has been talked about a lot on television news recently, and that is, would in-person voting sites where a small number of poll workers encounter a large number of contacts, voters whose IDs need to be recorded, would that constitute a potential super spreader event? And if so, should voting situations be discouraged by public health authorities?
Well, so again, the issue, what makes a super spreader event and what makes somebody a super spreader are several different things. But the key point there is the assumption that in that event, people aren't doing things to protect themselves. So again, if somebody is working at a poll and they are potentially asymptomatic or pre-symptomatic, and they are not wearing a mask, and they are not washing their hands, and people showing up aren't wearing masks, and they aren't washing their hands, then that would potentially lead to a super spreader event. Again, most of those situations can be avoided by doing things like wearing masks, having constant cleaning. As we know, in hospitals have not become epicenters of transmission because people are wearing masks in hospitals, and hospital healthcare workers, while obviously at higher risk, are generally wearing protective equipment that reduces probability of both them getting the virus and, if they have it, of spreading it, right? And so the reason I speak specifically to bars and restaurants is that both of those places are places where it's very, very difficult to wear a mask while being in an indoor environment.
So I think the next question that is being asked is pretty much related to what you're already talking about. And that question was, what data is there on the change in our infectivity in large group gatherings where face masks are actually worn?
Right. Well, so that becomes a difficult question, obviously, because most of the people who were the source of the super spreader event didn't know that they were the source, because they weren't actually all that sick, and that's why that they, somebody who's really sick will not generally not go out or not be the source of spread. So we know, and the evidence is pretty strong, that when wearing a mask, the amount of virus that any one person is spreading and spewing out will be much less. Again, if you're wearing a mask and you're sitting in a room with 5 other people and you're there for 4 hours or 5 hours of stagnant air, there's probably still a risk. But I think the difficult problem is that it's very hard to disentangle the several different things that occurred all at the same time in late March and early April, where you had changes in the weather, which are consistent with reductions in transmission and severity of respiratory infections in general. You had dramatic draconian measures to reduce transmission, including shelter-in-place orders, closing of most businesses, bars, restaurants, and the like, and in some cases, mask orders, right? And over time, those mask orders have been expanded while people have also started moving around. And of course, for every place that has a mask order, there is also a sizable contingent of people who are not particularly interested in wearing those masks or believing the evidence for them. I think that if you assume that there's a reduction in the probability of transmission when somebody is wearing a mask, then in a setting in which people are gathered, if people are wearing masks, then the probability of transmission and the probability of a super spreader event occurring goes down.
Thank you.
The magnitude of that is a harder question.
Yes.
I have a question for Dr. Klein about school reopening. How do you incorporate decisions about school reopening into models? And in a place like Maryland, where it looks like most of the schools aren't going to be opening live, how has that affected, models for the next few months?
Sure. So the models that we were running through most of the summer were looking at the possibility of opening or not opening schools. The issue around opening schools, so again, the way the model is built is that it has different age groups. And so we have built in the change in contact patterns among children and how that differs from adults. And one of the first things that we were asked back early in March was, should we be closing the schools? And is that enough? And the evidence, even at that time, was that closing the schools, if you didn't do anything else, was not going to have a dramatic effect, right? And the problem with schools, of course, even if you assume that they are hotbeds of transmission, is that kids themselves only make up a fraction of the population. So if you're not closing bars and restaurants and businesses and everyone else is going about their business just like normal, which again would probably be unlikely if you closed the schools, but if you took that as your base point, then closing the schools only has a marginal effect because a lot of people because the bulk of the population is actually between 20 and 60. On the other hand, if everybody is keeping their distance and there's very little transmission outside of schools, you open schools will increase the probability that you'll have large-scale that you'll have more of a surge. And if you have sort of ongoing transmission and it's starting to increase, opening schools will throw fuel on that fire. So, we've been looking at this in a couple different places. I mean, I think the difficulty is knowing when you look at schools, what is going to be the impact on child transmission if they're in school. So we assume that even if schools open, that at least in Maryland, that there would be a large number, or most kids wearing masks, and that there would be a large amount of social distancing. And thus transmission would be much lower in that setting than it would be normally if there was nothing being done. On the other hand, in some places that doesn't seem to be the case or may not be the case when schools open, and that would lead to presumably larger transmission. Now, of course, the difficult part, and this is the main thing we don't know a lot about, is what does it mean that kids aren't generally showing up in the hospital? And we know that they're at least between the high school age and middle school and high school age, they're definitely becoming infected and infectious. It's the younger kids, we don't know how infectious they may be. And there's a lot of studies which suggest that they might not be that infectious, but again, most of those studies happened after schools closed. So it's really hard to know what will be the large-scale effect of opening schools if kids are potentially infectious. Sorry, that was sort of a non-answer.
I know we're running out of time. I saw that there were a couple of questions specific to the Valley.
Yes, I believe Dr. Arenas, someone would like to know what kind of treatment are the underserved hospitals able to offer to COVID-19 patients?
So the hospitals are able to provide ICU care just like other places. The challenge is that we don't have as many beds, and certainly our staff is running, on fumes. People are overworked. We have had to bus in nurses from staffing agencies. One of the challenges is that, thankfully we're having people who get better or who are not so ill that they need to be in a full ICU. But one of the challenges is making that transition from the hospital to home. And so having places where they can go and self-isolate and receive oxygen. And so having oxygen tanks. And one of the ideas that's been floated is using hotels as a sort of step down unit where we can do remote monitoring. So it's really forcing a little bit of innovation in trying to find these solutions.
Okay, great. Thank you very much. I have two questions for Dr. Klein. The first one regarding his conceptualization of susceptibility, infectivity, and recovery. Does recovery, whether it's death or recover, what about getting reinfected? There still doesn't seem to be a lot that we know about the infectivity rate, and how do you put that into your assumptions?
Sure. So, as I was sort of starting at the beginning, the sort of SIR type model, very simplistic version of it, right? So you can assume that people move back from that R category back to the S category, susceptibility category at some rate or after a period of time. So currently in the models that we've been running, we've been assuming generally that there is no possibility of reinfection, but certainly that would alter the model somewhat and alter the implications somewhat if that were true. It certainly would make things in, say, New York a lot worse in the winter going into next spring, assuming no vaccine, because you would assume that a large number of people who are already infected may actually be transitioning back to being not infected, or to being susceptible. Unfortunately, we don't. I can tell you that I'm seeing something like 1% or even more of people within the system here who are testing positive more than 30 days later. But as of right now, most of those people are not believed to be reinfections. They're believed to be somehow remnant RNA, and they're not considered infectious. And as of yet, there is no guidance or evidence to suggest people are getting reinfected. We won't really know that for several months, I would guess. On the other hand, we're just starting now on serology studies, sort of estimate the proportion of the population that's actually been infected. And in Maryland, we're probably somewhere around, between 6 and 10% is the likely situation based on evidence from the models, evidence from some serology studies that have already been conducted that were not sort of well randomized. And that's, probably a little higher than other places in the country. We're getting some data from Red Cross suggesting similar things. So, I think for the moment right now, reinfection's probably not a great significant issue because you have such a large fraction of the population that is still susceptible. On the other hand, if people who have been infected and know they've been infected change their behavior based on that, then you could imagine that would be a significant problem.
Okay, great. Thank you. Two final questions. The first one is, speaking of herd immunity, which may require 50, 60, 70% of folks being infected. As you travel up the curve, you just mentioned maybe upwards of 10% have been infected, but when you get to 20% or 30%, does that lead to less transmissibility of the virus because it's not at 1% or 2%, or does it continue to be as transmissible until you get to this kind of magical herd immunity number?
Right. No. So again, if you think about it in the very simplest terms, right? Imagine somebody walks into a party in which 10 people are there and everyone's susceptible, then any one of those 10 people could become infected. If, on the other hand, you walk in and 50% or 20% of them have already been infected, that means only 8 people could potentially be infected. So the implication of having already a large number of people infected, even if you're not near herd immunity, is that the rate at which it will spread through the population will be slower. Again, part of the problem here, though, is that if it's largely super spreader events that's driving this, then the rate at which it was spreading earlier in the disease in March and April was really, really fast and really quite intense. And so if that was somewhat weather dependent and we go back to sort of that level of spread, then even though it will spread slower, it will still be quite significant.
Okay, great. Thank you. And last question is someone that you've studied modeling for many years now. What has surprised you about COVID? What lessons have you learned that you really weren't quite aware of prior to the pandemic?
Yeah, I mean, I think a lot of people were a little bit more surprised, myself included, at quite how over-dispersed the transmission was. And this might actually be more common in respiratory viruses than we have generally been led to believe, in part because, we don't, when you look at flu, it's hard to know who has and who hasn't been infected and how it transmits generally. But in this case, the rapidity at which it was spreading and the need in the models in order to have it spread that quickly, in order to get anywhere near the actual values of hospital occupancy that we were seeing was what was really scary.
Okay. Well, thank you very much. I'd like to thank both our speakers for an outstanding presentation, and thanks to Dr. Moreno for helping out with the Q&A, and Dr. Stahlback as well. Much appreciated. Next slide. As mentioned at the outset, this webinar has been recorded and will be available for viewing on Friday, and you'll receive an email to that effect when it's up on the website. Next slide. We will be continuing our webinar series next Wednesday at 3 p.m. We have a very interesting presentation on an alternative to disposable N95s, the reusable elastomeric half-mask respirator experience. And we have several speakers and a panel discussion to talk about this very interesting approach to personal protection. And that, again, will be next Wednesday, August 19th at 3 p.m. At this point, I'd like to wish everyone well and have a good day.